Well, good morning, and I'm glad there's a few more people than the number of speakers on this session here. Tuesday morning is M&M conference at Hopkins. I actually just got off, so I thought I'd change it up a little bit. Some people know me that I can't give a standard talk, so change it up a little bit. So my usual Christmas Eve tradition. So, about 4 o'clock we go out to dinner, 8 o'clock we get to midnight mass. So 2014, my daughter comes home, brings the new puppy. We're playing around, so okay, we're going to plan to do our usual thing. But then, about 10 o'clock in the morning, my resident calls me and said, Mr. Halsey, you're supposed to go home today, but he's been vomiting. And he's like spewing bile. It's coming out of his neck. It's like coming out in volumes. So I said, well, just try to put an NG tube back in, and then, it sort of slips out the drain site. And so, God, what's going on here? So I guess we better take him back. So emergently, so okay, let's get him back to the OR. So I look in, and say maybe 2/3 of the anastomosis is dehisced. And so we're trying to figure out what to do. So, God, it's Christmas Eve, what am I going to do? So I try to put the stent in, it's not going in right. Graft is pushing back in. So I open up the neck, I try to pull everything back up. I get the stent in, I suture it in place, but I hadn't really prepared him to do anything big. So I said, okay, well, just leave it for then. But then he's still vomiting around the stents coming out the neck. And I said, oh, geez, what am I going to do? So I was there for hours trying to get this thing. So needless to say, I missed dinner, I missed 8 o'clock mass, and I'll tell you what happens at the end. So I changed my talk a little bit after hearing some great talks yesterday by Dr. Morse, Dr. Blackman. We have some great talks later on about the complications and details. So I'm not going to go through details of how I fix these things. So I just sort of take the prerogative of being an old guy now. I can just sort of talk about stuff and not have to prepare anything. Remember, this is Esophageal Cancer Awareness Month. We did cupcakes for cancer. We got rid of 1,000 cupcakes in 4 hours. So I challenge everybody to do something during Esophageal Cancer Awareness Month. So again, no data, no stats, no bull. I'm just going to sort of talk a little bit. I don't have any disclosures or conflicts that pertain to this talk. So when you talk about factors about how esophagectomies go wrong, you can sort of categorize them in a couple ways. So one, were you sabotaged by somebody, or were they self-inflicted? Was it something that happened intraoperatively or postoperatively? Is it a known complication or something like totally out of left field that you can report? Was it done minimally invasive or maximally invasive? Did it happen in the chest, abdomen, or in the neck? Was it for benign disease or for malignant? And then finally, did you cross that bridge and you already divided the vessels and you already made the stomach, or can you back out? So some of us older people remember the expose saying the point of no return. That sort of like plays in my head a lot of the times when I'm thinking about should I keep proceeding with the surgery or not. So when I get into problems, I sort of pray to the 4 gods and goddesses of esophageal surgery, Mark Oringer, Shanda Blackman, Gail Darling, Daniela Molina with her VAT scope ready. So I think about what would they do? So I've heard them talk a lot about complications, and hopefully I've absorbed a little bit. So I thought I would break it up into some of the danger points in each of these 3 areas. So I'll start with the abdomen, because almost all of us work in the belly for our esophagectomies. So is it something that's injured, some known complications? Did you divide the right gastroeploic artery? Was it divided? Was it injured before? Is it gone from previous operations? If you're doing minimally invasive, did you put your ports in, and did you hit the bowel, or did you hit the aorta? And then there's some technical issues. Was the tumor stuck on this SMA or celiac axis? Did you get an IVC or a portal triad injury trying to do a Coker maneuver, or was there a large replaced left or common hepatic artery that should divide? I've had two of these, not personally, they were transferred in. We ended up having to do a aortic to hepatic artery bypass. And then transhiatal approaches. I've had one patient went in a cardiac tamponade. Somehow we ripped one of the epicardial vessels, and they went into tamponade. Luckily, we figured that out pretty quickly. Somebody had an MI just by sticking our hand up in there. So I'm sure some of you have had these things, the NG tube stapled in the conduit. So, it's just one of those little things that we keep forgetting. And then you let the residents do the J-tube, and they're putting the stitches or the Witzel through the J-tube. I had one time the student put the stitch right through the J-tube as they're sewing it to the skin, and we had to replace the whole J-tube. So little details. And as Dr. Morse said the other day, you have to be very meticulous. Every little step counts. So it's these little things that will end up getting you. As you go into the chest, if you're working on the chest, the patient accidentally gets extubated, while you're doing the anastomosis, because the anesthesiologist, no disrespect, is sort of fiddle-faddling with the double lumen tube, and then, oops, the double lumen tube is out of the mouth, and you have to sort of flip them over very quickly to reintubate them. Port injuries, as you're putting laparoscopic ports in, whether you hit the liver, the lung, or the intercostals. Stapler malfunctions with, you get that 99.99% donut. Obviously, it has to be 100%. Again, you could sew in the temperature probe. I always tell anesthesiology, pull the temperature probe back so you're not sewing it into the field, or the NG tube is stapled in the anastomosis. Transhiatal problems, massive bleeding, airway injuries. They luckily have not had any of these. You have a positive margin, and you have a short gastric conduit. So, what do you do there? Tumor stuck to the airway or to the aorta. The conduit is stuck in the belly, doesn't reach, it's dead. You're not quite sure if it's twisted or if it's dead. These days we use ICG to see if it's still alive. If you're doing things minimally invasive, do you get a thermal injury of the airway, or is it a mechanical disruption? And then, again, a handful of times, I really do study the CT scans very carefully. I've seen about 6 of these aberrant right retroesophageal subclavian arteries. I missed it one time, and luckily didn't have a problem, but our anastomosis was pretty close to it, so I put some muscle in between. If you're going up into the neck, some problems with the conduit, it doesn't reach, it's not viable. In the old days, we used to use the SPY technique, or the conduit gets twisted. You have a positive margin, you don't have enough length on the esophagus or the gastric tube, you have anastomotic issues as I previously described, and it's already been eloquently discussed by Dr. Blackman a few days ago. Again, make sure the NG tube isn't stapled or sutured in. I've had the resident put the NG tube down distally, and they dissected into the submucosal layer. And so again, I always check to make sure that the NG tube is in the lumen. You can suture or stitch the temperature probe in. The recurrent laryngeal nerve or nerves are injured, or sometimes if you don't study the CT scan well enough, there's a big goiter there and you're trying to do your neck anastomosis and it's in the way. I've actually had to call ENT to take out the thyroid goiter to do the anastomosis. So, you think you leave the room, you're going to go talk to the family if everything's going well, let the residents close, you think you're done, but you get called back because they're reintubating, and oops, we don't see the airway, we see the esophagus and actually a little bit of the mediastinum. And so had one time the ET tube tears your fresh cervical anastomosis, or they're transferring the patient to the bed, the NG tube falls out, the chest tube falls out, the J tube comes out. So that's a little bit of an issue. Very anal about the supercharged jejunum. It's sort of my preference after learning from Dr. Blackman. It's my preference after the stomach to use as a replacement conduit, and you lose the Doppler signals because the closure is too tight. So I'll just sort of finish up with some of my personal all-time favorite cases, just to share with you. I know A lot of you probably have some other cases. I've tried to imagine all the other possible things. I've had someone who had to have a perc trach in one of my patients who had to be ventilated for a little bit, and they just went right through the cervical anastomosis. I've had some patients get transferred with a dead conduit, and they end up being so sick, but they're young enough, we end up putting them on ECMO. So I've had 2 patients actually survive ECMO, so that is a reasonable option if they have a dead conduit, they're really sick, or patients who have the post-induction ARDS. This is a little bit of historical review. So bevacizumab and pembrolizumab we used to use for induction therapies. For Bev, we had some very bad bleeding problems. Actually, one of my patients died on the table because of excessive bleeding into the chest cavity, and it was from a transhiatal approach. Pembro, I had a patient that said he had effusions left and right, everything. I had to take him back to the OR 3 times for pericardial tamponade for these effusions. I went through the left chest, I went through the right chest, I went subxiphoid. So we ended up stopped using Pembro. And a patient, we had an aortic tear during a transhiatal esophagectomy, and so I couldn't see quite up through the inlet, so I packed them and called vascular, and we put a TVAR stent in. One time I was trying to put a retrosternal graft in, and it was just didn't really get it high enough, and so it was because the liver was too big, so I had to call the GI guys in to do sort of a subanatomic liver resection. One time somebody transferred a subcutaneous graft they couldn't swallow, well, because they didn't take out the SC joint. Boy, that was a pain in the butt to try to get that joint. I actually took the whole graft out because it was so ugly. And then recently I had a guy who was transferred in. He had esophagectomy 2 years ago, but he kept leaking. He's got a gastropleural fistula, and he also had a duodenal cancer. So we ended up doing a Whipple, ended up closing things up. So again, so anybody know the Kobayashi Maru? Every case you can get out of. So this is from Star Trek. So when the wheels come off, what do? You phone a friend, you stay calm, and as we've talked about, you talk in teams. So again, thank you for, I forgot to tell you. So what happened, I ended up going to bed. When I got home, I was in the doghouse, and this guy ended up having 25 operations to ever get him to swallow again. So again, sorry I went over, and thank you for your attention.
Thank you, Dr. Yang. As our next speaker is making her way down, I'm going to ask you one question. You mentioned several opportunities for sabotage or potentially perioperative collaboration, depending on how we're looking at it. I'm curious, what's the most common topic of discussion between you and your anesthesiologist during these cases?
Well, I actually start preoperatively, so I do send out a message the night before to the attending anesthesia and to the resident, like what kind of tube, because we all do different esophagectomies. So my partners like to do Ira Lewis, I like to do transhiatal, so do I need an endotracheal, do I need a double lumen tube or not? So that's the one thing. And as already been talked about at this meeting, if you ever get put on pressors, make sure anesthesia, lets you know. I always look up at the screen and seeing what what the pressures are. And then when I do the transhiatal, I think I mentioned this the other day, and I always tell them 10 minutes ahead of time, I'm going to do the dirty deed, which is sticking my hand up through the hiatus, and so prepare for hypotension. Post-operatively, we've been sending them mainly to the step-down unit, but I guess if they go to the ICU, obviously we do the handoffs, but try to limit the fluid, no pressors, so we do try to tell them to minimize the tissue swelling because it's only living on one or two vessels in venous drainage, so we do try to minimize the fluid and the pressor support.
Thank you.